For small biopsies and tissue, the guideline recommendations really speak to small biopsy and cytology specimens. There are, as I talked about, two main ways of doing that now: EBUS TBNA and CT-guided or transthoracic needle biopsy. One incredibly important piece from my end is what separates those two is EBUS's ability to stage and diagnose. So a CT-guided biopsy is an outstanding procedure to go after a primary lung nodule or lung mass, but it's not typically used for mediastinal sampling, just given the risk and depth that the needle would have to penetrate. EBUS, on the other hand, can do both. So we can access lymph nodes, we could diagnose, and then end stage all in the same procedure. The important piece on both ends, and all guidelines recommend this, is that the concept that core needle biopsy is a necessary component should not be thought of anymore. There is ample and robust data now looking at fine needle aspirates as a primary driver to obtain these samples. And I'll talk about how we do that and why we've been successful. One of the big pieces that you'll see in all of these guideline recommendations is that ROSE is recommended when available. And for us, it's an incredibly important, if not the most important aspect of our procedure, because it allows instantaneous feedback to ensure that we have an adequate sample, that we understand the degree of necrosis in that sample, and that we're able to achieve an adequate specimen for biomarker analysis.